For our final presentation today, I'd like to welcome Ruth Belflower Midkiff to present on risk assessment and risk planning. Ruth is a seasoned professional with over 20 years of experience in public health and infection prevention and control. Ruth currently serves as the IP Program Coordinator for the Kentucky Department for Public Health, Healthcare Associated Infections, Antimicrobial Stewardship Prevention Program, and oversees the statewide Regional Infection Prevention Program. In her diverse roles as an infection preventionist and epidemiologist, Ruth has supported healthcare facilities across the continuum, including acute care, long-term care, outpatient, and dialysis facilities. Her educational background includes a Bachelor of Biotechnology from the University of Kentucky and a Master's of Public Health and Epidemiology. It is a long day. Apparently, I can no longer speak. Excuse me. Along with a Bachelor of Science in Nursing at the University of Rochester. Throughout her career, Ruth has been actively involved in professional organizations, having served as president and president-elect for the Association for Professionals in Infection Control and Hospital Epidemiology, and has contributed her expertise to National APIC Practice Guidelines Committee and served as the APIC liaison to the American Association of Critical Care Nurses. Ruth is certified in infection control and long-term care CIC, demonstrating her commitment to excellence in the field. At this time, I'm going to stop sharing my screen and turn the presentation over to Ruth.
Hello, we are sharing our screens, correct? Let's see. Okay, great. Well, thank you very much for having me today. As Jolie mentioned, my name is Ruth Belflower Midkiff, and I'm going to be talking about the infection prevention plan and how it is informed by the infection control risk assessment. And hopefully, if time allows, I would like to give a brief overview of the services provided by the Kentucky Regional Infection Prevention Program. Oops. There we go. Okay, so today, again, we will be reviewing how the infection control risk assessment informs the infection prevention plan and all the components of both of those, and looking at the infrastructure of the KRIP program and our services and how we can help your facilities if you need assistance with anything infection prevention and control related. So after this presentation, I hope that you all will be armed with the knowledge and tools necessary to discuss the facility's infection prevention plan, as well as to describe how you complete an annual infection control risk assessment and how you can use this to frame and draft the contents of your plan. Additionally, you will learn how to develop appropriate and measurable program goals and be able to explain how you will evaluate your facility's progress towards meeting these goals. Lastly, I will equip you all with the knowledge and information to obtain support through our program at KDPH. So we'll jump right into things. So what is the purpose of a facility infection prevention plan? First and foremost, it serves as a detailed roadmap of your infection prevention and control program, outlining its function, infrastructure, and program activities, as well as goals. It is the key component of every robust infection prevention and control program and describes a comprehensive framework for effective program implementation. At its very foundation, it's essentially the meat and potatoes of your program. It answers the who, what, when, where, and why of what your facility's program does. And secondly, as we all know, it is a regulatory and accreditation requirement, and it must be formally written as well as reviewed on an annual basis. It should describe how your program will be monitored, so how oversight is performed, whether that be through for instance, your quality committee, or perhaps your facility has a standalone committee to provide oversight. It's also required that your plan be informed by your annual risk assessment And the plan is also supported by written policies and procedures addressing all those topics of infection prevention and control. And these policies and procedures, as well as your plan and risk assessment, must be based on nationally recognized standards from organizations such as CDC or the World Health Organization. And the infection prevention plan also serves as a sort of gap analysis of your program. It helps you to determine those opportunities for improvement in your program, and it's a mechanism to capture strategies to prevent and control infections. I'm sorry, I went on. And this is mostly done through completing the annual risk assessment. And lastly, it's a mechanism to capture your program progress through the end of the year program evaluation. So as you can imagine, and as most of you are probably aware, there is a lot to infection prevention and control. The infection prevention plan is nothing less than that. It's very comprehensive, and it includes a lot of details and content. So I just want to take a moment to highlight the broad areas of information that are included in your plan. I've briefly mentioned that the plan outlines the infrastructure, and this would include like a description of the roles and responsibility for program staffing, namely your infection preventionist, and in the long-term care setting, this may also include your director of nursing, your administrator, and so on, those other key leadership roles that support your program. Another part of the plan is an authority statement, and this is a description of what kind of governance your infection prevention program has to implement its strategies to prevent and control infections. It also outlines again how the program is monitored and what oversight is provided. So as you probably gathered, there's a lot of detail in the plan as well about how you'll conduct your annual risk assessment, and the plan includes all of your annual goals along with corresponding objectives to meet the goals. Outside of these overarching topics, the plan also includes information on more specific IPC related areas that detail your surveillance activities, both for healthcare associated infections as well as other reportable diseases, facilities prevention activities. This may be auditing of your IPC practices or implementation of transmission-based precautions and so forth. Another area that is described within is communication, both within your facility and with external partners or other healthcare organizations, as well as emergency preparedness efforts for things such as the influx of potentially contagious patients and residents, maybe a utility failure or even water contamination. The plan moves on to also discuss how your facility would respond to an outbreak, and also exposures amongst anyone that comes in and out of your facility, be it staff, patients or residents, family, or visitors, or even those contract workers not employed by your facility. Occupational health is addressed in your plan. This might include illness reporting or fit testing and vaccination requirements for your staff, and IPC education for both staff as well as residents or patients and visitors is also described. For long-term care facilities, antimicrobial stewardship is another area that's addressed by your plan as well. And the plan can also outline those supporting documentations, as I've mentioned, those policies and procedures outlining things such as EVS processes or other processes, linen management, and those types of things. And lastly, a description of how your program is evaluated is included in this plan. So I know this seems like a lot, and it is a lot, but if you take a systematic approach and take it bit by bit using your infection control risk assessment, then creating your plan and completing the risk assessment is very doable. And as you can probably imagine, the first year that you are drafting your plan or completing the risk assessment, that's where the bulk of the work will occur that first year. But in an ongoing basis, updating the plan and updating your risk assessment becomes easier and easier as there are some values that will remain the same and not change as much. So it's really a front end loaded bulk of work for facilities to do that, but it really is the foundation of your program and will really help steer you in those opportunities for improvement and having a robust program. So we'll jump right into this annual infection control risk assessment because this is pretty much where it all begins. Now, this risk assessment requires a multidisciplinary team approach. It cannot be left up to just the infection preventionist to complete an annual risk assessment. It really takes input for all of our partners. And as we know, infection prevention and control is everybody's business. So folks from facilities management may be at the table, environmental services, even human resources. There are so many key players to infection prevention and control. So this infection control risk assessment is no different. It will be a multidisciplinary team approach. Again, for regulatory or accreditation requirement, it is an annual task to be completed from your program. And it's informed by a lot of data sources. So not only is it data that is specific to your facility, it also requires information on community level demographics that includes but isn't limited to those populations that your facility serves, the population in your community at large, the types of services your facility offers, those community partners that you collaborate with, of course, community and facility specific infection rates or even healthcare associated infection rates, as well as if you have information available on device utilization for things like Foley's or central lines. And if you have past year's surveillance data or audit data for compliance rates on core activities like hand hygiene and PPE, or also environmental cleaning and disinfection. All of these data sources are very important to help inform your infection control risk assessment. So I wanted to present this as a screenshot of what a potential template looks like. There are, and I have included several key resources and tools in this presentation for an infection control risk assessment. This particular example is one that I have created over my 15 or 20 years in the field. I've pulled from many different great tools and resources out there to tailor it to specific settings that I have worked in. But this one can be edited to be applicable to any of those settings. And I am happy to share this tool after the presentation, as well as the templates for plans and for goals. After I can provide those to Julia and she will be able to share them. So I wanted to review the components, the major components of the risk assessment. The core of the risk assessment is coming up with a list of potential events or failures that you may see related to infection prevention and control in your facility. And we're going to go into more detail about what these are and how they're written. But this column A, this is an Excel spreadsheet. So this is column A in the spreadsheet, is your list of these potential events and failures. And then each of these events and failures are scored on 3 different domains: on the probability of occurrence, risk impact to your patients or residents, and system preparedness. And all of this is used to compile an overall risk level score and a priority category, which that information will then be used to help you write your goals and prioritize the activities of your program. So to go into a little bit more detail on each of these areas, let's look at the possible events failures first. You can see in this screenshot here, the way this tool is set up is again kind of by infection prevention and control domain. Here, program infrastructure is the example that I have, and under that is a list of potential events and failures. So these are statements written kind of in negative phrases, describing if there's a failure to do a key infection prevention and control practice, or if there is a lack of a certain component. So under program infrastructure, for instance, there could be the phrases written lack of required policies if your facility is missing some key policies or procedures, or inadequate program staffing. Those are just a couple of examples of how you can write these statements to then be scored on your on those 3 domains that we are going to look at in just a moment. So let me go back here. So some of the other domains that are captured include your MDROs and HAIs, procedure-related infections, injection medication safety, prevention activities, environment of care, occupational health, and this continues on through this list. It's very similar to many of the sections of your infection prevention plan too. So that is really how they inform each other. And finally, there is this kind of catch-all category, other, where you can add things specific to your facility, because ultimately this tool should be used in such a way that you are tailoring it to the needs, to the services, to the populations at your facility. So after you have come up with the list of potential events or failures for your facility, as I have already mentioned, these elements, or each one of them, are going to be scored on the 3 domains. First, the probability of occurrence. And what this means is how likely is this event or failure to occur in my facility. So you will ask yourself that according to what the statement is. And then we have the risk and impact to residents, which means if this event or failure does occur, what is the possible risk or impact to patients or residents? And from the risk impact domain, you really want to look at this in terms of worst case scenario. What is the worst possible outcome that could happen for when you're scoring these elements? And then lastly, scoring on facility preparedness. You're going to ask yourself, how ready is my facility to respond if this event or failure does occur? So each of these domains have their own scale, if you will, for scoring. So probability is scored on values of 0 to 3, where 0 equals never, meaning that this event or failure will never take place at the facility. And I, over my experience, have not seen many scores of 0 here, but I have seen a lot of 1s, 2s, and 3s. 1 is rarely, so this event will rarely occur. 2 is it may or may not occur. And 3, it's likely to occur. And risk impact is scored on the values from 1 to 4, as you can see here, 1 being no harm to residents or patients, up to 4 being life-threatening harm. And again, you want to look at this as a worst case scenario. And finally, for facility preparedness, this again is scored on a 1 to 4, where 1 is that the facility is very well prepared to respond should this event failure take place, through 4, which means the facility has nothing in place to respond to that potential event. So once the elements have been scored in these 3 domains, an overall risk level and priority category is calculated. And this is calculated by adding up or determining the summation of the values for the probability plus the risk impact plus the preparedness. And then you can have these priority risk categories, and you will have to define these and determine these based on your facility and based on your experience. In this example, I have classified them of values less than 5 to be of low risk, low priority, values 5 to 7 being of medium risk, medium priority, and anything above 7 being scoring at a high level or being a high priority. And again, using these values, that will help you prioritize the activities and those things that you would like to improve upon for your next program year. So taking into consideration the information and the pieces and parts of the risk assessment that I just presented, I want to run through an example. We're going to look at an example for hand hygiene noncompliance. So first, we want to score this on the probabilities. So we're going to ask ourselves, how likely is a lack of hand hygiene compliance to occur in my facility? So for this particular element, there are things that you want to consider. And this may be, okay, you've noticed perhaps there aren't alcohol-based hand sanitizers in key locations, maybe near medication prep areas. Maybe they are not in resident or patient rooms. Also taking into consideration things like if you have it available, previous compliance rates, maybe your compliance rates are low, so that you know that hand hygiene noncompliance is somewhat of an issue. So when taking those things into consideration, for this example, I've determined that this score would be 3. It's likely that in this fictitious facility that we will observe hand hygiene noncompliance. So then we have to think about the risk impact to patients or residents. And again, we're thinking worst case scenario. So if you ask yourself, what is the worst thing that could happen to a patient or resident if a healthcare personnel did not perform hand hygiene or did not perform it correctly? Could it spread a life-threatening infection? The answer was yes, it could. For instance, maybe a staff person's hands are contaminated with C. auris, which we know can have a pretty significant mortality rate. And then if that's transmitted to an immunocompromised resident or patient, then it's possible that it could be a life-threatening risk to a patient. So for this particular example, I scored the risk impact to patient as a 4. And then when you move on to facility preparedness, how ready is my facility to respond to high rates of hand hygiene noncompliance that maybe, for example, have led to a CRS outbreak? Again, there are things you have to take into consideration, mostly regarding available resources, maybe from a staffing perspective or from the ability to obtain additional hand hygiene supplies. So are there adequate staff available to perhaps take on a performance improvement initiative surrounding hand hygiene? Or are there other staff available to assist with audits maybe? Does the facility have the funds or the means to obtain additional supplies and mount more alcohol-based hand sanitizer? So if you're taking these things into consideration and you're answering no to several of these, then it may be that the facility is not adequately prepared to respond to this particular event or failure. So in this scenario, I scored the preparedness for the facility as a 2. So then if we take a probability score of 3, a risk impact score of 4, and a preparedness score of 2, and we add those together, we get an overall risk level of 9, which according to our scales lands in the high category. And again, here's the example of the qualitative risk levels. And so using these, you're going to be able to, again, prioritize those program activities and write those goals, and also then do some program evaluation at the end of the year and see where your program is. So this is just a screenshot to show you a more complete ICRA template where there are several elements or potential events and failures that have been scored, how they're scoring. I'm a big proponent of color coding. I think it's visually pleasing, and anyone could pick this document up and see where your facility is placing their efforts or seeing what needs to be prioritized. And I think that's helpful that anyone can read it. It would be easily explainable to a surveyor or anyone like that as well. And again, it's an Excel template, so it can be filtered and sorted. So after everything is scored, you can then generate a list of all of these potential events and failures that have fallen out with a risk level that is high. And so from this list, you will want to look at those events that have scored the highest. And here we have one event that has scored a 9. And we know that that will likely be a priority activity. And then from the list of those left over that are still high, we obviously cannot address all of these. So it really does take some thought and some prioritizing of the remainders of the events or failures. And again, you will have to consider those available resources your facility has, any maybe project improvement initiatives, and always regulatory and accreditation requirements will impact what your program priorities will be. And so using that list, you will want to write anywhere from 6 to 10. It may be less depending on how robust those goals are, the work included. It may be more if they're smaller, easier goals to obtain. But you will write 6 to 10 of those program goals that will go into your infection prevention plan, and those goals will have applicable objectives and methods to reach those goals. And many of you are probably familiar with the SMART acronym. It should be used and implemented to write your goals and also to look at your objectives. So we have the S stands for specific. So in other words, clearly state what is being accomplished with this goal. Measurable, you want to have discrete actions identified and measurable progress that you can document. Achievable, you want them to be practical according to your program resources, realistic to your program purpose, and timely, meaning that progress can be made over the next year or two of the program. Additionally, for goals, you'll determine a frequency for how often action will need to be taken on that goal. You'll assign a responsible person or persons to implementing the actions, and also indicate how oversight will be completed to see that the goals are accomplished. And again, just through my experience and lots of trial and error, I should say, I have developed my own template that I'm happy to share that presents goals in this table format. So again, anyone can pick up this document, from an EVS staff person to your administrator or your medical director, and they can easily see what the program goals are and how those are going to be addressed. And this table is organized again by IPC domain. And you can see here, those examples include infrastructure, hand hygiene, water management. And there's a column for the SMART goals and clearly defined objections, as well as a short description of methods that'll be used to meet the goals. And as I mentioned, you would indicate the frequency. There may be some like hiring additional human resources support that the frequency is just going to be once, unless there are multiple positions to hire for, of course. Or there may be other things that occur on a monthly basis or annual basis. So that is what is captured under frequency. And then the responsible party. Again, infection prevention and control is a multidisciplinary approach. It's everybody's business. It does not all fall just to the infection preventionist. And lastly, this reporting mechanism. Is data going to be reported on a routine basis to your quality committee or your IPC committee? So organizing it in this table format just makes it very easy to follow. And again, for anybody to pick up and see where your program is headed. And in addition to that, you can use this table for the final piece and the final regulatory requirement, which is to evaluate your program. So I have found it easiest to kind of just use that same table I just presented and add an additional column to the end labeled progress or evaluation, and then using your existing data sources or documentations to track the progress. And over my experience, I've come up with these 5. I mean, again, you can tailor it to your facility, what meets their needs. That you can label the progress and also use the table to document barriers and efforts made towards. And that is how you can perform the program evaluation. And so here is the example of how I took that table and I added this last column where I am capturing progress. And as you can see, I've used these color-coded labels to document what's been done. I have documented the details that for hand hygiene, for instance, the 80% compliance rate goal was met with whatever the goal was this year, and that it will continue on into the next year. This is an ongoing goal. And then for something that maybe you do encounter barriers, you can document what barriers you've encountered, what kinds of things that you've done to try to address that. And this table would be included as an appendices to your plan. So all of those documents will be right there together. You can easily hand those over to a surveyor or someone from Joint Commission or whoever may be accrediting, and it's all right there. Or you can hand it to any of your staff member and they're easily going to be able to see how your program is structured. So in summary, having a written formal infection prevention plan and using an annual risk assessment to inform that plan is a regulatory requirement. And this really is the foundational roadmap for your program. And it really helps organize all your activities. It helps you to stay on track and to see the progress you've made. And I've reiterated this several times, but it really does take a multidisciplinary team to do this. Your plan and your risk assessment, they are data driven. You will use past and current data to inform those. And just as a suggested timeline, and what I have found to work well when I was working as an IP in a facility, is to really gather that data and try to start scheduling a multidisciplinary team meeting or a couple of team meetings in January or February after those annual compliance rates or what other data has been gathered. And then really in March, trying to have your updates, edits, and new goals and updated risk assessment completed to be approved by your governing committee, so that then over the rest of the year, you will be able to really work towards reaching those goals. As I mentioned, there are several resources and tools available. These are some great outlines and toolkits and templates for writing infection prevention plans, as well as these are some great templates available for a risk assessment. So you will not have to reinvent the wheel. We all know how busy we are as IPs, and any way we can save time is very helpful. So just quickly, because I know we're getting towards the end of the day, I just wanted to review our program and let you know how you can contact us, that we can support you in drafting an IP plan or completing a risk assessment. So prior to COVID, Kentucky Department for Public Health HAI-AR program had 5 core staff. And as you can imagine, the workload was tremendous then and became even greater when the COVID pandemic hit. And so CDC made a lot of funding available to states to really bolster infection prevention from the state level. And Kentucky was fortunate enough to obtain funding to expand the staffing for the program. And so the Kentucky decided to take a regional approach to infection prevention and control across the state through the KRIP program, in which the state was divided into 10 regions, with each region having 8 to 15 counties in the geographical areas. And for each of those regions, a regional infection preventionist, or we call RIP for short, was hired local to that area, so they could be available to those facilities and really be the boots on the ground. This map here is available on our website for you to look at. You can identify who your regional infection preventionist is using this map. And this table of contact information is also available, and you can feel free to reach out directly to your applicable regional infection preventionist or to myself as well. And so the goals of our program are really to bolster our infrastructure throughout Kentucky and to identify and address any opportunities across the healthcare continuum related to infection prevention and control. All the information we collect and the work that we do, we utilize to then partner with KYIP, for instance, to develop these education and trainings that are tailored to the needs of our constituents. We serve as the subject matter experts for facilities and community partners. There's a lot of collaboration in our work within the health department, with local health department, with associations, and so on, to prevent HAIs and antibiotic resistant organisms. And we also support facilities during outbreaks and help support mitigation efforts to stop the spread of disease. The bulk of our work is done through these infection control assessment response visits. So these, in 2015, CDC, or it might have been 2016, CDC began developing standardized tools to conduct infection prevention and control assessments for facility programs. There used to be 4 tools available: acute care, long-term acute care hospitals, and then for nursing homes, dialysis, and outpatient. And these tools were developed to provide a comprehensive program assessment, but they have been edited and revised over time, and now contain different modules that you can pick and choose from to tailor it if you have a specific infection prevention and control need. We can do these assessments either by an on-site visit or even virtually through Zoom or Teams. And these assessments are conducted through a qualitative portion, where it's a face-to-face or an over the phone or over the computer conversation between your RIP and the facility to discuss contents of policies, qualitative information on practices. But there's also this quantitative portion to it, where we conduct direct observations, we come in as like a second set of eyes. After we do an assessment, we provide a very detailed summary report with a long list of resources and tools for facilities to use to implement to address opportunities for improvement. But it doesn't just stop there. We're available for ongoing support to help address any barriers during implementation and so on. The key things that I want to point out is our program is non-regulatory. We are not regulatory in any way, shape, or form. We are here just to be a mechanism of support to facilities. And we do keep information confidential and leave it up to facilities to share if they want to share with a surveyor, for instance, if they come into the facility. And all the services we provide are free of charge to the facility as well. And this is just a screenshot of one of or a portion of the tool. And as I mentioned, there are now kind of 11 modules that make up the whole tool that address these core domains of infection prevention and control. And then there's also the observations tool that addresses looking at and assessing those practices of the healthcare personnel while they are working on the floor. And this is a screenshot, just a little snippet of what the report looks like. It's in a table format, so it helps the facility easily track the recommendations we're making, but they can also use it kind of a checklist for implementation, as well as this long list of resources that we provide. And quickly, in addition to doing those assessments, we also provide education and training services, mostly in partnership with other organizations. Like our immunization branch has developed this respiratory virus vaccine training. We can come into your facility and give this as a face-to-face presentation to promote vaccinations amongst staff. We can also aid facilities in conducting fit testing, whether it's obtaining supplies, or we can train a trainer so that there's someone on site that can conduct fit testing. We can review policies or plans, or even help you get initial fit testing completed. Additionally, we also offer ongoing IP mentorship or orientation onboarding. We know that there is high staff turnover, especially in nursing homes, but also there are a lot of new IPs. So we are there as a resource to help those get comfortable in their position and be able to prioritize the many, many tasks and things that an IP has to do. And so here are some of the key websites that you can go to. Our main program website. This is also a link to the CDC tools, as well as the vaccine in-service that I mentioned. And I want to just take a moment to say a big thank you, especially to our program manager, Andrea Flincham. The work that we do could not be done without her expertise and her great leadership. And you know, I cannot say enough good things about our regional infection preventionists either. We have a really great team, and we have developed a lot of great collaborations with community partners and healthcare partners. And it's all about a team approach. So I just wanted to take a moment to say a special thank you to all of those that partner with us, and KYIP as well. Julia, you've been great, and I very much appreciate your support. And so I will open it up for if there are any questions. I will see if I can get to the chat.
So it looks like there were a couple of questions. So one question was around does the infection prevention nurse have to be checked off on fit testing before they can provide education?
Before providing education, not before providing education, but if they were going to be the one conducting fit testing for their employees, it would be kind of a train the trainer, where we would check them off, make sure that they're trained in that way. But like on orientation, if you're just orienting new hires to fit testing, you can provide education without being checked off.
All right. And it looks like, so clarifying question. That is what I meant, is to provide fit testing. So I guess, Christy, are you asking if to provide fit testing, the infection prevention nurse has to be checked off on fit testing? Is that your question? Okay, that is correct, Ruth. So does the infection prevention nurse have to be checked off on fit testing before?
Right, we would recommend that anybody who's conducting the fit testing of their employees, whether it be the IP or some other representative, that they do have the trainer and be checked off to ensure that they are familiar and can conduct standardized fit testing, yes.
Okay, and who trains that infection preventionist?
Well, that's something we can do. Our staff is trained to train the trainer. We would be happy to come in at your regional infection preventionist to train you and check you off so then you can do it at your facility. I believe there are several resources for education that you can do online to get that, or vendors often will also provide that kind of training.
Fantastic. All right. I believe that is all the questions that we had. Thank you very much, Ruth, for your assistance and for presenting for us today. It was fantastic and will be really helpful, I think, when we do our tabletop exercises for our Sims.